Some bones may have the tympanic membrane, some bones may not have the tympanic membrane. See, this is the one magnification. Here, the first step in temple bone dissection is fix the temple bone in proper anatomical position. That is very, very important. After fixing, I told you, see, this is again I am showing you the tip of the mastoid inferiorly, the zygomatic process anteriorly, squamous part of the temple bone superiorly, and this is the anatomical position you have to keep. And second thing, here you have to keep in mind the skin. You see how I am shaving the skin. See, this is the skin, tooth forceps. Take a tooth forceps and shave the skin here like this. But in live surgery, you can see how much respect I am going to give for the skin. See how much respect I am going to give to the skin. You can notice, if you shave it well, what will happen? The exposure of the tympanic membrane will be very good for you. See, will be very good for you. And why we are giving two bones to you is, do mistakes in the first bone and we make a note whatever the mistakes you are committing in the first bone, and please don't try to do the same mistakes in the second bone. That is very, very important. Now, before doing the Meringout mixed saline, before doing the Meringout micromat, you have to wash it well, the external artery canal, to take out the squamous debris. See, take out the squamous debris in the external artery canal. Now, I told you there are three suture lines. One is here, this is the probe, this is the tympanomastoid suture line, this is the squamo-tympanic suture line will come here, and outside the landmark is the spine of Henle, 15-day knife spine of Henle. The depression here is called fossa mastoideum. See, when I am dissecting, this is the fossa mastoideum. Okay, this is about the part of 15-day knife. Vendile, piston vedam, grommet venda. See, this is the just taking out the periosteum. When you are dissecting also, take out the periosteum nicely. Once you take out the periosteum, there is no chance of slipping of your burr. That is very, very important. Okay, there is no chance of slipping of the burr. Now, so there are three important suture lines. One is the tympanomastoid suture line here inferiorly. I will go for low magnification otherwise. This is the tympanomastoid suture line, very important landmark for the facial now. The second is the squamo-tympanic suture line. Sometimes what will happen, this prominence is called spine of Henle. Sometimes the anteriorly there is a prominent squamo-tympanic suture line, that is called anterior spine of Henle. See, I will show you, try to dissect and show you the squamo-tympanic suture line. See, this is the squamo-tympanic suture line. See, if you see, the squamo-tympanic suture line is a prominent. You see, prominent, very prominent here. This is the squamo-tympanic suture line. This is called anterior spine of Henle. I will go for high magnification, show you how the squamo-tympanic suture line looks, how it is called anterior spine of Henle. See, this is the anterior spine of Henle. Okay. Now, I told the tympanic membrane will be divided into 4 quadrants. One curve through one line, see, one line passing anterior to posterior, like this, bisecting the unbow, goes like this, and one line goes parallel to the long process of incus and inferiorly divided into anterior superior quadrant, anterior inferior quadrant, and posterior inferior quadrant and posterior superior quadrant. What is the place for doing the myringotomy grommet? There are two things. One is the incision. The incision should be radial. This is called radial incision. Why the incision should be radial is, when you give the incision radially, the number of fibers what you are cutting, the blood vessel supply come from periphery to the center like this. The blood supply come from the handle of the malleus. You can see the blood vessels here. You see, I think, are you able to see the blood vessels here? See the blood vessels?
Yes.
These are the blood vessels. These are the blood vessels. So, if you give a radial incision like this, no damage will happen to the blood vessels. And if you give any circumference incision like this, what will happen? You are cutting lot of blood supply, and that leads to the permanent perforation syndrome. That is the cause for the perforation in the tympanic membrane. So, the radial incision is preferable than the circumferential incision. Coming to the site of the myringotomy, why the anteroinferior quadrant is preferred than this is the posterior-inferior quadrant. Why not the posterior-inferior quadrant? When you want the grommet for short time, you keep the grommet in the anteroinferior quadrant. When you want the grommet to be placed for long time, please place the grommet in the posterior-inferior quadrant. Why? What is the difference? The epithelial migration theory. The epithelial migration will be slow in posterior-inferior quadrant. The grommet, it may last for longer time when you keep in the posterior-inferior quadrant. When you keep the grommet in the anteroinferior quadrant, the grommet will get extruded from 2 months to 2 years. The epithelial migration will be faster in the anteroinferior quadrant, and it is slow in posterior-inferior quadrant. And when there is no space, what to do? You can keep the grommet in antero-superior quadrant, and not the dangerous area for myringotomy grommet is the posterior-superior quadrant. And when there is no space, you can keep at least very small ventilation is there in the middle ear. In the antero-superior quadrant, you can keep the grommet here. And the most dangerous area for myringotomy grommet is the posterior-superior quadrant, where there is a cauda tympani nerve and the ossicular chain. I noticed in my experience the youngsters damaging the cauda tympani nerve, taking over the ossicles, and injuring the facial nerve in myringotomy grommet. So, if you keep in mind how long you want the grommet for short time, keep in the anteroinferior quadrant, the grommet for long time, keep in the posterior-inferior quadrant. The dangerous area for myringotomy grommet is the posterior-superior quadrant. Never attempt to do myringotomy grommet in posterior-superior quadrant. In the anteroinferior superior quadrant, if there is no space for myringotomy grommet in the anteroinferior quadrant or posterior-inferior quadrant, go and keep the myringotomy and do the myringotomy grommet in the antero-superior quadrant. Now, any doubts about myringotomy grommet, please? No? Oh, excellent. Now, we will go for the second step of the surgery, that is the stepidotomy process operation. And here you see, this is the short process of the malleus, and while giving incision, please turn the temporal bone just 2 millimeters above the, this is the short process of malleus, 2 millimeters above the short process of malleus. Give the incision like this. See this, and here while coming to the, this is the right temporal bone, while coming to the 9 o'clock position, see this 9 o'clock position, see, while coming to the 9 o'clock position, please come away from the incision, see, away from the tympanic annulus like this, and while going to 6 o'clock, don't slip the knife like this, just see, keep the knife rocking movement, see, superior to inferior rocking movement. This is very, very important, see. And whatever the skill you want to gain, how to do the autological work, you have to start learning from here. Don't commit any mistakes. Try to do, this is the live surgery. See, once you think this is a live surgery, there is no chance of you are committing mistakes in the live surgery also. See, now after giving the incision, try to elevate the flap, see like this, try to elevate the flap. Depending on the freshness of the bone, you may get a good flap, and if the flap is not fresh, you may not get a flap. There is a chance of getting tear in the flap, but please don't mind. And my sincere request is to keep all the bones in the, whatever the water given in the bottle to you, please don't keep the bone outside, okay, don't keep the bone outside, always keep the bone in the water, that bottle given to you, always keep that bone in the bottle. That is very, very important. See this, see, I am giving the incision, same time I am elevating the flap up to the annulus. See, now this is the annulus, suction. See, don't keep the suction on the flap, another important step. If you keep the suction on the flap, there is chance of the flap going into the suction. See, don't keep the suction into the, see, don't keep the suction under the flap. Try to fold the flap anteriorly like this. See, I told you the flap will bend depending on the its freshness. See, now I am taking a smaller section. అదే నిశ్చితులది taking a smaller section, കുറച്ച് cotton കൊടുക്കണം, കുറച്ച് cotton కొడు. I am taking the smaller section and taking a cotton wool. See this, taking a cotton wool, cotton ball, ఇంత చిన్నది వెరీ స్మాల్, దీంట్లో వేసే కాటన్ బాల్ ఫాస్ట్ ఇవ్వమ్మా, ఎంతసేపు ఏంటమ్మా ఇవ్వు. సో దిస్ ఇస్ ది కాటన్ బాల్, and I hope this DVD will be given to you by Dr. Chaitanya Rao. And see, this is the cotton ball. Take the support of the cotton ball and fold it, suction, fold it. Now take a curved pick, see, take a curved pick, open the inside the mucosa here, you see, inside the mucosa, and try to identify the structures as soon as you reach. One, this is the annulus. Annulus is fibrous condensation at the periphery of the tympanic membrane is called the annulus. This is the annulus, and here immediately a white in color like the annulus is the cauda tympani. Now this is the cauda tympani now, and now see here the fold is not, the tympanic membrane is not getting folded. You see, just I gave incision, suction, and here there is a notch called the notch of Rivinus superiorly in the bony canal. There is a notch called the notch of Rivinus. This is called the notch of Rivinus, and this is the mucosa giving incision parallel to the fibrous annulus. Now drum elevator. After giving the incision, see how I am taking the drum elevator to dislocate the fibrous annulus from the tympanic sulcus. So the another new word what we learned, one is the tympanic annulus, the second is the tympanic sulcus. Tympanic sulcus is a groove at the medial end of the bony external auditory canal where the fibrous annulus goes and sit. This is the incision given, that is the annulus. Gently dislocate the annulus from the bony sulcus. You see here, gently dislocate, don't break the annulus, try to dislocate the annulus from the sulcus. Okay, stapes knife. I told you this is not a so fresh, that is why this flap is not folding. See, this flap is not folding properly. See, there is the, see, gently elevate the flap from the tympanic sulcus. Okay, now keep it flap like that, and here I am going to keep the cotton ball, changing the position of the cotton ball, changing the position of the cotton ball. See this, changing the position of the cotton ball like that. Okay, now cord probe. This is the notch of the Rivinus. The first word what we learned is the fibrous annulus. The second word what we learned, the tympanic sulcus. Third anatomical word what we are learning is the notch of Rivinus. Notch of Rivinus is notch in the superior wall of the external bony external auditory canal. You see, this is the some fibrous attachment of the pars flaccida to the notch of Rivinus. This is I made a cut. Now folded the tympanic membrane. They used the handle of the malleus as a fulcrum. Everything is clear? Hello?
Yes, sir.
Clear. Now we try to identify the important, always whenever you are proceeding for the surgery, identify the anatomical structures. One is neck of the malleus, second is the short pars of the malleus, third is the notch of Rivinus, fourth is the chorda tympanoid, fifth is the long pars of incus, sixth lenticular pars of incus, seventh incudostapedial joint, eighth head of the stapes, ninth the stapedius tendon. If you turn little downwards, you can see a bony projection in the posterior part of mesotympanum, few millimeters inferior to the second genu. The bony protrusion is called the pyramid, and here there is a prominent bulbous area in the middle ear. This is nothing but the promontory formed by the basal tone of the cochlea. And if you see, just postero-superior to the promontory is the oval window covered with the footplate of the stapes. This is the stapes, and postero-inferiorly suction. Post-inferiorly, see, there is a depression called the round window. It is covered with the secondary tympanic membrane. So beautifully we identified the landmarks. Now I am turning the head of the patient superiorly to identify the crura of the stapes. Here, this is the posterior crura of the stapes. The posterior crura of the stapes is thick and short. This is the anterior crura of the stapes. This is thin and long. We will go for little more magnification. See, you can see beautifully the crura of the stapes. You can see, can you see the crura?
Yes, sir.
So beautifully you can see the blood vessel going here. That is the anterior crura, this is the posterior crura, and still beautifully you can see the footplate of the stapes. So when you are able to see the footplate of the stapes, the long process of incus like this, no curating may be required in this bone. And now I am taking a small suction to suck out the secretions over the secretions over the footplate. See, now I am sucking out the secretions over the footplate. You see that the secretions over the footplate. That is the secretions over the footplate I made. Now here we have to see how the literature of the stapes surgery. Now we are going to do the stepidotomy process operation. In the 1960, Dr. John Shea started doing stapedectomy processes operation. The hearing loss in case of the stapedectomy is 1.1 decibels per ear. And next improvisation in the stapes surgery is the platinectomy, partial platinectomy. Partial platinectomy means removal of the part of the footplate of the stapes, that is the posterior part of the footplate of the stapes, that is called posterior partial platinectomy, and later develop the large fenestra stepidotomy process operation. Now, what is the recent trend in our Hyderabad ENT Research Foundation we are following is the small fenestra stepidotomy process operation. In that also we modified the technique called small fenestra reverse stepidotomy process operation. What do you mean by reverse stepidotomy process operation is, here we are making the fenestra like this now itself. After making the fenestra, see, keep the piston between the fenestra and the long process of the incus, then take out the suprastructure of the stapes. This is called the reverse stepidotomy process operation. What is routine stepidotomy process operation is, take out the suprastructure of the stapes, make the fenestra and keep the piston. What are the advantages of the reverse stepidotomy process operation is, you are beginners, when you want to do stepidotomy process operation, by after curating, by curating itself there is a chance if the curate slips anteriorly, what will happen, there is a chance of dislocation of the incudo-stapedial joint. Not only the chance of dislocation of the incudo-stapedial joint, there is a chance of dislocating the incudo-malleolar joint. Please take care, the curate should not go inferiorly or medially. Second thing, when you try to take out the suprastructure of the stapes, there is a chance you may take out the entire footplate also along with the suprastructure of the stapes. So this is why once you do the tympanotomy, try to check the mobility of the malleus. The malleus is mobile. In case of the autosclerosis, there is the malleus, try to move it. See, malleus is mobile. Try to move the stapes. The long process incus is fixed. This is mobile. and try to move the stapes is fixed. This is the second step after identifying the landmarks. First step is tympanotomy, second step is identify the landmarks, the third step is the check the mobility of the malleus, incus and the stapes. Okay, now we confirm the stapes is fixed. So I told about the stapedectomy and reverse stepidotomy, small fenestra stepidotomy process operation. I am stabilizing the flap carefully. Now there are various ways of making the fenestra in the foot plate. Various different techniques, and when I am demonstrating the live surgery, you can see how I am doing the live surgery. But here I am going to show you what you have to do it. Suction. What you have to do it. Okay. Now, whenever I go away from the field, please one of you inform me. Now you can see beautifully the foot plate. There are 3 perforators here. I will show you. These are the perforators. I will show here. Coming to the any blue sheet or green sheet. This is the green background. See, these are the perforators. I think you are able to see. This is the first perforator 0.3 millimeters, second perforator 0.6 millimeters, and this is third perforator. This is 0.8 millimeters. These are the perforators. Are you able to see?
Yes, sir.
Clear? Now I will come back to the field. I am using first perforator. Be gentle. Hold the perforator like a pen. Like a pen in your hand. You see, now the foot plate is focused so beautifully. Amir, I think you noticed we are using, Amir Hussain, we are using the HD, full HD camera. I think maybe picture quality different from the last demonstration. Okay, Amir Hussain is there? Yeah. And where to make the fenestra? Before trying to make the fenestra, I want to tell you the fenestra were to make only in the posterior part of the foot plate. Why were to make the fenestra in posterior part of the foot plate is, you know, the sensory epithelium of the vestibule is divided into 2. One is the saccule, the second is the utricle. The saccule is placed 1.2 millimeters medial to the medial surface of the foot plate. The utricle is placed 1.5 millimeters medial to the medial surface of the foot plate. So, posterior part of the vestibule is deeper than the anterior part of the vestibule. Keep in mind, we will compare the meningotomy grommet with the stapes surgery. You have to keep the grommet where the biggest space available in the mesotympanum. The biggest space available in the mesotympanum is the hypotympanum. Like that, the biggest space available in the vestibule is the utricle. Utricle is placed, the sensory epithelium of the utricle is placed 1.5 millimeters medial to the medial surface of the foot plate. Is it clear?
Yes.
Yeah. So you know that where to keep the fenestra, where to make the fenestra in posterior part of the foot plate. So now I am taking the number 1 perforator and I am using the high magnification. See, this is the number 1 perforator. Trying to make the fenestra. See how gentle, be gentle, you see. Be gentle, don't apply any pressure. Suction. Taking out the secretions. See. Trying to make the fenestra. See this. See how I am trying to make. I will change the direction of the microscope a little bit. See, now again I am going. Not made. See this. Suction. In live surgery, I use the skeeter drill, and unless the footplate is thick, it takes only 1 minute to make the finished draw. But this is the best way of learning the how to work on the footplate. See how gentle I am doing, like a live surgery. Always please feel that you are doing live surgery. See, still not, the finished draw was not made. Now, are you able to see the finished draw? See? Are you able to see? Say one of yes. Yes or no? Okay. That is the finished draw what I made. Now I am enlarging the finished draw with the same refine. See, now I enlarged. You can see beautifully the finished draw. See, after making the finished draw, suction. See, don't keep the suction on the finished draw. See, I am sucking at the margin of the finished draw, not on the finished draw. Very, very important. Okay. Now I am taking the second perforator. I am taking the suction off second perforator and enlarge it with the 0.5 millimeters refine. See, gently gone. Now take the third perforator. Even though we are careful, sometimes the footplate may get fractured like this. That is called ice fracture. Don't allow the footplate slipping into the, see, footplate slipping into the vestibule. Try to enlarge it. Enlarged. Now I am taking 0.2. 0.2. I got 0.2 right angle pick. Try to focus on the footplate. Try to take out the bony spicules, whatever they are hanging into the, see, whatever they are hanging into the vestibule, gently take out. Oh no, definitely. When I am not, please let me know. Like this, you see, I told you I never get disturbed. You see, even live surgery also, please do like this. Ask me the questions, okay? See this. Try to take out the bony spicules. See, and try to keep the annulus intact. Take out the bony spicules. See, like this. And one more bony spicule is there anteriorly. Hope my hand is not coming. See, like this. Now the finished draw is ready to accept our piston. There are two ways of measuring the length of the piston. One is using the measuring rod. I will show you. Changing the little adjustment. Now see, one is using the measuring rod. Use the measuring rod from, see, finished draw to the long process of the incus. See, try to see, finished draw to the long process of incus. This is 4.5. The other is take the piston, crocodile forceps. Take the piston, check the distance, how the piston is lengthy piston. I got very lengthy piston, but check the length from the, see, there is the footplate, and here this is, see, too lengthy. This is another way to check the length of the piston, but this is not, I never follow this method. For demonstration sake, I demonstrated you like that. Now I am going for the one magnification. See, for this very high magnification, I am going for the one magnification again. See, this is the one magnification. This is the jig. I want to change the to show you the jig. This is the jig. I want to keep 4.5 millimeters piston. This is 4.25, 4.75, 4.5, 4.25. Okay. I want to keep 4.5 millimeters piston. See, 4.5. See here. This is 4.5. Now turn the jig. This is called jig. Turn it like this. Cut. Suction occurred. Cut the excess piston. This is very lengthy piston. I know that. Very lengthy. Chop it. One cut. Not clear for you. I think now it is clear. Yeah, one cut. See, inferior to superior. One cut, superior to inferior, like this. Then try to enlarge the fenestra. The opening. No. This is the eye of the piston. 1 minute. This is the eye of the piston. Try to open the eye. Keep in the jig or catch with your fingers like this. Try to open the eye. It is not clear. Just give me 1 minute time to focus. Okay. Hope it is clear for you. Very clear.
Yes.
Open the eye of the piston like this. Okay. After opening, take the crocodile forceps, and catching of the piston also very important. The catching the piston also very important. Catch the piston like this. See, parallel to the shaft of the piston. You see, that is the shaft of the piston. Go parallel to the shaft of the piston like this. You have to catch like this. You see. And now after catching and keeping the piston in your hand, try to focus again into the field. This is one magnification I told you. I am using the one magnification. See, I think very clear for you. Now again I am taking the piston into hand. Just give me 1 second. Yeah, now the piston is in my hand. How I am going? Try to watch. I know this is difficult to keep the piston to the long process of incus because we went inferior to the crura. It is difficult. You see, it is difficult. Always we try to make the fenestra from this side. Then you can keep the piston like this. Here, what are the things we did is we never curated here because there is a good space there. Second thing is we never made the fenestra from superior between the facial nerve and the foot plate. Now there is no alternative for us. In this case, take right angle. After making the fenestra, right angle, take the right angle. Now again I am going for high magnification to show you beautifully what the steps I am doing. You see, this is high magnification. Try to cut the mucosa around the incudostapedial joint like this. See, the incus should not get dislocated. That is very important. See this, the incus should not get dislocated. Be gentle, cut the mucosa around the incudostapedial joint. We cut the mucosa. Take scissors, micro scissors, and cut the stapedius tendon. Cut the stapedius tendon like this. Okay. Now we take a short right angle and try to fracture the suprastructure of the stapes. Keep the right angle on the head of the stapes. Continuously apply pressure towards the promontory. See, continuously apply the pressure towards the promontory like this. See, when continuously apply the pressure towards the promontory, the stapes will come out. In case of the autosclerosis, beautifully the stapes will come out, beautifully it come out. See now that is the stapes, crocodile forceps. See, taking out the suprastructure of the stapes, taking out the suprastructure of the stapes. Again we will see how is the suprastructure of the stapes. See, that is the suprastructure of the stapes. I am keeping it here. I will show you the suprastructure of the stapes after 2 minutes. Now I am able to see the bony spicules. I don't like to allow the bony spicules into the vestibule. Take out the bony spicules. Don't take out the entire foot plate, only enlarge the fenestra and keep it the place ready for the piston. And here again I am taking the piston into my hand. I will show you how to hold the piston. Let me go to the table. I will try to show you how to hold the piston. Again, this is very important. Okay, this is the piston. Is it clear? Piston.
Yes.
Yes. Now hold the piston. Don't drop the piston on the ground. It is difficult to search for the piston. Okay, and try to open the eye again. I open. Hold the piston like this. This is very, very important. You see, very important. Hold the piston like this. Now again, come back to the field of surgery. Here that is the fenestra, beautiful seen fenestra, and this is the long process of incus. And try to keep the piston first into the fenestra, that is keeping the piston in the fenestra, and then hang to the long process of incus. See that? Hang to the, yeah, I am making it center. Okay, is it center now? Center now. Okay, clear? Cord flow. See, and Amir Hussain, if you notice, this technique of stapes is different than what the type of stapes surgery I do it. See now, I pushed the piston into the long process. After this, try to crimp the head of the piston. Try to crimp the head of the piston like this. See, there is a fiber on the crocodile forceps. Crimp it. See, and the piston should snugly fit into the long process of incus and should not tightly crimp it. Now, and there are various ways of doing the fenestra. There are various ways of doing the stapes surgery, but here the anatomy allowed me to do without any curating of the posterior surface of the bony meatus. This actually we have to curate from here to here, then do all these things, but without all these things I am able to do the stapes surgery. Only the anatomy allowed me like this. Don't expect, you can do same thing all the bones, and I will show you the different technique of stapes surgery, and after another 10 minutes. Okay.
Can you show us facial neck position?
Yeah, now I will show you the facial now. See, this is the facial now. Are you able to see? This is the horizontal part of the facial now. Are you able to see?
Yes.
Here descent. See, are you able to see?
This
When I am in the descent, according to the Baxter, B-A-X-T-E-R, Baxter, he says in 55% of the cases the facial nerve is descent. According to the Mariosana, in 50% of the cases the facial nerve bony canal is descent in the horizontal segment or the fallopian canal. So keep in mind, more than 50% of the cases the facial nerve bony canal is absent in the horizontal segment or fallopian canal of the facial nerve. Please be careful while doing the stapes surgery. Sometimes the facial nerve may come and overhang onto the foot plate, those are the conditions. There is a chance you may lose the facial nerve. There is a chance the patient may get the facial paralysis. Okay, so this is actually I plan for reverse stepidotomy process operation because the anatomy is not allowed me to do reverse. First I made the fenestra, taken out the suprastructure and kept the piston. This is called stepidotomy process operation, not reverse stepidotomy process operation. So after making the fenestra, try to take the soft tissue from the post-auricular region. See, try to take the soft tissue from the post-auricular region. See, I am taking this soft tissue, small pieces of the soft tissue from the post-auricular region, and I will keep this soft tissue around the fenestra. Always I do like this only. See, I am taking this soft tissue, that is the soft tissue, just I am taking to keep around the piston. You see here, this is the areolar tissue or the fat. Keep it like this. And sometimes some people they may use the temporalis fascia, or sometimes they may use the vein graft also. See, my experience always I like to do the simplest procedures. The things should be simple. Always I like the simplest things, no complications and nothing, and the success will be high. So that is why another piece of the fat I got it. I am keeping again around the fenestra. And there are two tests called the bending test and hanging test. The fat I am keeping superiorly and inferiorly. What is bending test and what is the hanging test? The bending test is like this. Bend the piston, apply pressure on the shaft of the piston, bend it anteriorly. If the piston comes out from the fenestra, that indicates the piston is short. Hanging test, take a right angle probe and lift the long process incus gently superiorly, and if the piston is too long, you may not be able to see the shaft of the piston. Those things for theoretical sake I am telling you, but I am not doing here properly. Why means when you try to do these two tests, there is chance of dislocation of the incus. So I don't like you are committing mistakes here also. I think you are able to understand. Okay. So you are telling about the reverse stepidotomy process operation, and is it possible to do the reverse stepidotomy process operation in all the cases? If you ask me, yes, you are right. It may not be possible. The anatomy may not allow you to do the reverse stepidotomy process operation. When the anatomy is not allowing, there is no alternative. You have to do like this only. And how to cut the crura? You can use the skater drill. You can use a right angle pick and go on scratch on the crura, and then only when there is the narrow niche. What do you mean by narrow niche? Is the promontory growing towards superiorly and the autosclerotic focus over the foot plate, the facial nerve growing towards the promontory. The stapes will get sandwiched, the suprastructure of the stapes will get sandwiched between the autosclerotic focus growing from the promontory and autosclerotic focus growing from the facial nerve, and you may not be able to see the foot plate. Then what to do? You try to take the skater drill or take 0.2 millimeters right angle, try to scratch on the promontory, try to scratch on the facial nerve, don't damage the facial nerve, try to get the view of the foot plate and then make the fenestra. And how to know whether the foot plate is thin, thick, moderately thick and obliterative. A thin foot plate looks bluish in color, a moderately thick foot plate looks whitish blue in color, a thick foot plate looks white in color, and the obliterated foot plate looks the ivory white in color. These are the four thickness, the name terminology given for thickness of the foot plate. Okay? Any doubts about stapes? I am coming down to you. Any doubts?
No, sir, thank you.
Thank you. Yeah, I think now this is the time for the breakfast. Dr. Chaitanya Rao and Mr. Raj Kiran, can we give the break for breakfast? Hello? I am coming down to you to show you. Yeah, I am coming down to you to show you the another technique of the stapes surgery.